Good morning, everyone. Welcome to the grand case presentation of NUR 633 FNP Practicum. We are Group 2 and we are called the Millies Group. Our group will be discussing the Pediatric Health Assessment, and may I introduce to you the Dreamers. From your left is Gemma Viray, Lalaine Villahermosa, Ishmael Gistopa, Paulina Gonzalez, Marlita Castillo, and yours truly, Romel Alcantara. Our case study is a 12-year-old Hispanic male accompanied by the father and brother, a cooperative and pleasant kid. Chief complaint: I want to join our varsity team, per patient. HPI, patient came into the clinic requesting for a physical exam. Patient wants to join soccer sports in school with his brother. Patient is active and has been actively playing different sports in his school and plans to enter school varsity team with his brother. Allergies, patient denies. Medication, patient is on multivitamin once daily. Immunization, updated with all childhood immunizations. PMI, patient denies any major childhood illnesses. Denies chickenpox. Social history, denies any surgery. Dental history, last dental exam was July of 2020. Family history, mother has hypertension and father is obese. Social history, patient is a student active in school activities and participates in outdoor activities. Patient lives with his parents and younger brother and has a very good family support. Patient has a non-smoking household. In the review of systems, patient denies any fevers, denies chills, denies sweating. On vital signs, blood pressure is 100/76, heart rate of 67, respiratory rate of 20, temperature of 97 degrees, height is 5'5", weight of 131 pounds, BMI of 21.8, vision test is 20/20 on bilateral eye, on Snellen's test. Hemoglobin is 12.2 grams per deciliter. UA dipstick, the color is yellow, pH of 5.2, clarity clear, specific gravity of 1.010, negative for ketones, nitrites, leukocyte, hemoglobin. Last PPD test was negative as of June 2016. Physical examination, patient is well nourished, cooperative, in no acute distress. The exam was unremarkable. Our next presenter is another successful individual who has over 30 years of nursing experience. She also owns and operates an adult daycare facility in Las Vegas, Nevada. Ladies and gentlemen, let me welcome you, Ms. Lalaine Villahermosa.
I'll be discussing the psychosocial history of the client. As part of the adolescent annual clinical preventive service visit, assessing the patient's activities and behaviors are important. However, effective communicating with the adolescent takes time, and building a rapport is essential. As a nurse practitioner, before doing any assessment, we should discuss with our patient about the importance of confidentiality and that no information will be disclosed without their consent. The internationally used tool to find out about issues in adolescents' lives is called the HEADS assessment. As the interview is in progress, the nurse practitioner should also observe the client's nonverbal reaction, like avoidance of eye contact, decreased effect during interview. H stands for the home and the living situation of the patient. You would ask the patient questions like, tell me about your living conditions at home. Are you living with the parents, with your aunts and uncles? Are you sharing rooms? E and A stands for the client's education and activities. You can ask the client, so tell me about your school. Do you have specific activities that you like to join? And do you have any favorite people that you are dealing with at school? The D part is the diet, drugs, and depression. This part of the interview, you must be able to establish rapport already with your clients. We are using the PHQA or the PHQ-9 modified tools, in which in this the PHQ-A stands for the Patient Health Questionnaire with the 9 questions. And this tool is an instrument for screening, diagnosing, and measuring the severity of depression. The scores ranges from 0 to 27. 5 to 9 will be the mild depression, 10 to 14 is the moderate depression, 15 to 19 is moderately severe depression, and 20 to 27 is the severe depression. As we continue to assess the client using the PHQ-A or PHQ-9 modified, we have to be prepared to ask our clients some open-ended questions like, some people at your age are some doing already or trying to do some alcohol and drugs. Is that something you have experienced? How often do you do it? And how do you obtain them? The next assessment is the SSS assessment, which stands for the Sex and Suicidal Safety. Questions like, are you seeing anyone at this time? Is it a boy or a girl? Some people at your age start having sex, and have you done this? Any contraceptive methods that you've been using? Or do you want anybody to talk to about these situations? I'll be discussing partly the physical assessment of the client. Visual acuity is very important. If corrected acuity of less than 20 or 40, needs a protective eyewear. Lungs, you have to auscultate if they have some wheezing. Abdomen, if they have any organomegaly or splenomegaly noted in the abdomen. Genitals, we will be talking about the Tanner stage of the client. In this stage, the client is in the Tanner stage of 2 and 3, and I'll be discussing that further. For the skin, if their patient has some rashes and any impetigo and herpes. Patient's lymphatic, there is no lymphadenopathy. Neuro, the patient makes sure the cranial nerves are within intact. And most important of all is the vital signs of the client and the BMI, because the low BMI will indicate that the patient has some eating disorder. As I've mentioned earlier, under genital assessment, the male Tanner stage of the patient in our case scenario is stage 2. It's the first sign of male child experiencing sexual maturation. There is an increase in testicular size. The skin of the scrotum will also begin to thin and redden and enlarge, while the penile length will remain the same. Pubic hair starts to grow as well, mainly on the penile root at the stage of Tanner stage 2.
She will be discussing part of the pre-physical assessment with focus on cardiovascular assessment and musculoskeletal assessment. Let me welcome you, Ms. Paulina Gonzalez.
Okay, moving forward. So for the cardiac examination, the cardiac exam should include measurement of blood pressure and the resting heart rate. The PP should be measured in the arm while resting. Auscultation, the examination should listen for murmurs and other abnormal heart rate or heart sound like gallops or clicks. Assess for femoral pulses and compare for radial artery pulses to exclude coarctation of the aorta. Location of the PMI. Palpate the pulse felt at the PMI for increased intensity and lateral displacement of apical impulse that suggests hypertrophic cardiomyopathy and heart failure. For asymptomatic bradycardia with a heart rate of 40 to 50 beats per minute may present in fit athletes. It does not prevent activity. Most well-trained endurance athletes have resting sinus bradycardia. For routine use of EKG, for pre-participation physical is not recommended for screening purposes by the American Heart Association and the American College of Cardiology and other organizations. This is a 2-minute musculoskeletal screening examination. This screening examination less than 2 minutes to complete. This is adopted by the AAFP and AAP. The general musculoskeletal screening examination consists of the following 14 steps. First step is inspection. The athlete standing facing toward the examiner, looking for symmetry of the trunk and upper extremities. Step 2 is forward flexion, extension, rotation, and lateral flexion of the neck. Range of motion and cervical spine is what we're looking for. Step 3 is resisted shoulder shrug, watching for strength and trapezius muscle. For step 4, resisted shoulder abduction, looking for the strength and deltoid muscle. For the fifth step, internal and external rotation of the shoulder, looking for a range of motion and shoulder joints. Sixth step is extension and flexion of the elbow, watching for the elbow and wrists. Seventh step is pronation and supination of the elbow. So we're watching for the elbow and wrist also. Step 8 is clenching fist, then spread fingers, looking for the hands and fingers range of motion. Step 9 is inspection. The athlete is facing away from the examiner, watching for symmetry of the trunk and upper extremities. Step 10 is back extension and knee straight, looking for spondylosis or spondylolithasis. Step 11 is back flexion with knees straight, facing toward and away from the examiner. Watching for the range of motion, thoracic and lumbosacral spine curvature, hamstring flexibility. Step 12 is inspection of the lower extremities, contraction of quadriceps muscles like alignment and asymmetry. Step 13 is duck walk, 4 steps. Motion of the hip, the knee, the ankle, strength and the balance. And the last step is standing on toes, then on heels, watching for the symmetry, calf strength, and balance. The BESS is a nice to know test since concussion is a hot topic in sports. So BESS stands for Balance Error Scoring System Test. This provides a portable, cost-effective, and oblique method of assessing static postural stability. The BESS can be used to assess the effects of mild head injury on static postural stability. An athlete's balance is tested in 6 positions. Each position is tested for 20 seconds, counting the number of errors or times at the athletes move out of position. Examiners should begin counting errors only after the individual has assumed the proper testing position. The athlete performs a 1 leg, 2 legs, and tandem stance both on a solid surface and on a medium density foam pad. Step A, double leg stance on firm surface. Step B, single leg stance on firm surface. Step C, tandem stance on firm surface. Step D, double leg stance on foam surface. Step E, single leg stance on foam surface. And step F, tandem stance on foam surface. Errors are A, moving the hands off the hips. B, opening the eyes. C, step, stumble or fall. D, abduction or flexion of the hip beyond 90 degrees. E, lifting the forefoot or heel off the testing surface. And F, remaining out of the proper testing position for greater than 5 seconds. The maximum total number of errors for any single condition is 10. If an athlete commits multiple errors simultaneously, only 1 error is recorded. So in this form, this is a busy slide. This is a pre-participation evaluation form. The American Academy of Family Physician, or the AAFP, the American Academy of Pediatrics, or AAP, and American College of Sports Medicine have endorsed a standardized pre-participation athletic evaluation form that addresses the important aspects of the history and examination. The next slide, this form is available through the AAP website. This is an important thing to know for the pre-participation examination form. It is a standardized questionnaire, is easily reviewed, and designed by experts. So be familiar with the form and questions asked, as the parent or athlete will bring this form to you to complete once cleared for sports participation.
The next presenter is dubbed as the cooking queen of cohort 25, no other than Miss Marlita Castillo.
Let's talk about assessment. Based on the history and clinical findings, the primary diagnosis to document in the encounter is well adolescent care. ICD-10 code is Z00.129. Counseling for nutrition, exercise, and screen time and BMI should also be coded to get credit for it. This patient is overweight based on the BMI for age percentile growth chart and should provide lifestyle modification and weight loss counseling. For the screening, the goals of the health maintenance visit in the school-aged children 5 to 12 years old are promoting health, detecting disease, and counseling to prevent injury and future health problems. The AAP and USPSTF have made a variety of recommendations about specific screening tests for school-aged children. For the hearing and vision, the AAP recommends routine vision testing for 5, 6, 8, 10, and 12 years of age using an age-appropriate visual acuity test such as the Snellen chart. The USPSTF recommends vision screening at least once in all children 3 to 5 years of age to detect amblyopia or its risk factors. Referral for formal optometry evaluation is recommended for visual acuity less than 20/40 for children 3 to 5 years of age or less than 20/30 for children older than 5 years. And also in children if there are more than 2 lines of difference between the eyes. The AAP recommends screening in hearing loss using audiometry at 5, 6, 8, and 10 years of age and once between 11 and 14 years of age. Conduction hearing thresholds greater than 20 decibels indicate possible impairment and warrant referral to audiology or ENT. The USPSTF does not have an active recommendation regarding hearing screening in school-aged children. Let's talk about depression. The U.S. Preventive Services Task Force, or the USPSTF, recommends screening for major depressive disorder in adolescents 12 years and older. Recommended validated screening tools for depression in adolescents include the Patient Health Questionnaire, or the PHQ-9 for adolescents, and the Beck Depression Inventory for primary care. The USPSTF concludes that there is insufficient evidence to assess the benefits and harms of depression screening in children 11 years and younger. Next one is tuberculosis questionnaire. The screening for this is recommended for high-risk children. TB risk assessment questionnaire is designed to determine whether a tuberculin skin test or interferon gamma relay assay or IGRA is indicated for pediatric patients. According to recent CDC guidelines, a TST is preferred for a child less than 5 years of age. If a child is 5 years of age or older and is foreign-born, then an IGRA is preferred. For the laboratory testing, routine laboratory testing is not recommended as part of the pre-participation physical evaluation in the absence of symptoms. For CBC, this is not recommended for athletes who receive regular health maintenance care and have no symptoms of anemia. However, it may be indicated for teenagers who do not have ongoing medical care. Some experts advocate screening menstruating female athletes for iron deficiency, especially if they run long-distance events. For high-risk adolescents, recommends the screen for STI, HIV, syphilis, gonorrhea, and chlamydia. Also, check urinalysis for male to look for white blood cells as a sign that the bladder is irritated or infection in the urinary tract. For the dental screening, children should brush their teeth twice per day with a pea-sized amount of toothpaste containing fluoride and should see a dentist twice per year for a checking and cleaning. And let's go to immunizations. Immunizations are a cornerstone of health maintenance. There are 2 sets of immunization recommended for all school-aged children. The first set should be administered at 4 to 6 years of age and include DTaP, inactivated poliovirus, MMR, and varicella. The second set should be administered at 11 or 12 years of age, includes Tdap and the first dose of meningococcal vaccine and the first dose of human papillomavirus vaccine if not started previously. Influenza virus vaccine is also recommended, usually yearly for all children 6 months and older during the flu season. Should document varicella, MMR hepatitis A and B status. And also for certain high-risk groups may need additional vaccine. Okay, let's talk about health education anticipatory guidance. It is really important to document counseling, nutrition, safety, smoking, alcohol, drugs, puberty, peer interaction, sexual education, and preconditioning for sports. Anticipatory guidance is appropriate at all ages, but it is particularly important in school-age children 5 to 12 years old because they are establishing patterns of behavior that may last a lifetime. AAP issued a 2016 policy statement recommending that screen time be limited to 1 hour daily for children 2 to 5 years of age, for older children and teens, and they caution against too much screen time. But there's no specific time limit, and recommending that physicians encourage families to adopt a family media use plan. Families should be counseled on vehicle, water, sports, firearms, home environmental safety, and also social safety. Also, address any concern with parents and siblings. Let's look at dietary counseling recommendations, okay? This table includes American Heart Association dietary counseling recommendations for school-age children which are endorsed by AAP. It is important to counsel them on healthy lifestyle practices. They should eat a balanced diet high in fruits, vegetables, whole grains, low-fat or non-fat dairy products, beans, fish, and lean meats, while limiting sugar, fast food, and highly processed foods, and be educated on appropriate portion sizes. For the physical activity recommendation, they should engage in 60 minutes of moderate to vigorous physical activity each day, such as walking, running, swimming fast, jumping jacks, playing basketball, volleyball, or biking. And for safety counseling and recommendations, unintentionally injury is a leading cause of death for school-age children in the United States, mainly due to motor vehicle crashes, followed by drowning, firearm fatalities, and fires and burns. Most injuries are thought to be preventable and predictable, and outpatient counseling on injury prevention has been shown to decrease injury rates in children. School-age children should be taught safety precautions. You have to remember that. So this patient is cleared for participation in sports soccer without restrictions. Thank you.
Our next presenter is Philippines' best internal medicine, Dr. Ismael Estopa.
Hi, good morning. I'm Ismael Estopa. I'm going to talk about clearances. There are 3 different kinds of clearances that can be given to a patient. One is full clearance for participation. 2 is clearance to participate with limitations. And 3rd is exclusion from participation pending further evaluation. And the disqualification from sports participations can be dizziness with exercise, and favorable body mass index or systolic BP elevation, visual acuity defect, presence of a heart murmur or musculoskeletal abnormality, and those with patients who have asthma history. The restrictions from participations can be due to specific conditions. They are cardiovascular disease, uncontrolled hypertension, musculoskeletal neck injuries, prior concussion, Osgood-Schlatter disease, asthma and exercise-induced bronchospasm, fever, and obesity. The decision to disqualify an athlete from sports participation is made in light of the specific sport which the individual seeks to medical clearance to participate. A pitfall to keep in mind is discouraging athletes from general sports participation when they are disqualified from a particular sport. Athletes might still be able to compete in other sports and experience the benefits of participation. Most disqualifying conditions are conditions that can revolve or controlled with medical or surgical interventions. Invasive sports participation. Concussion is a big topic, but I will only focus on what you need to know and when can an athlete return to play. California state law states that return to play cannot be sooner than 7 days after evaluation by a physician was made the diagnosis of concussion.
Our next presenter is a very successful individual, well respected in her community. Ladies and gentlemen, may I welcome you, Ms. Gemma Viray.
Good day, everyone. My topic for today is legal issues. Both adults and children in healthcare must engage in an active process of parental permission and childhood assent. In order to avoid legal issues, protection of the health and safety of an athlete and avoidance of exposure of significant risk of sudden cardiac death must be prioritized. No matter what the age may be, informed consent is an integral and essential part of the healthcare system. This is why both adults and children must actively work together, and children as well as adolescents' opinion must be valued when it comes to decision making in clinical practice and research. From a medical perspective, the health and safety of an athlete must be prioritized. This means that the athlete must not be exposed to a significant risk of sudden cardiac death. This should be the primary factor when it comes to determining the exercise of clinical judgment and to making medical recommendation. Liability exists if an athlete cleared for athletics suddenly and inappropriately results in harm. In conclusion, the goal of pre-participation physical evaluation is to maximize the health of athletes as well as to ensure their safe participation in sports. Anticipatory care and prevention for young athletes should include infectious disease prevention. There are multiple benefits when it comes to participating in a sport. Not a single individual should be deprived of this, and so prevention to negative health outcomes must be the top priority. The physical examination should focus on the cardiovascular and musculoskeletal systems. However, further evaluation is needed for those who have heart or lung disease, bleeding disorders, musculoskeletal problems, history of concussion, or other neurological disorders. Beyond this, children who participate in organized sports should also be aware of infectious diseases. For instance, skin infection may be contracted due to physical contact with other players. This skin infection may grow to become more serious problems in the future if left untreated. Joining organized sports is beneficial as it enhances memory and thinking skills, reduces stress and anxiety, improves brain function and concentration, and sparks creativity. It is also good exercise for the body, so it will remain healthy. But of course, there are risks involved. Medical experts must be aware of the prevention so there will be no longer a rise of any legal issues, as well as safety and welfare of the patient will be ensured.